Hello, and welcome to Line 1, Your Health Connection. I'm your host, Dr. Jillian Woodruff. Approximately 1 in 5 heterosexual couples struggle to achieve pregnancy after 1 year of trying to conceive in the U.S. Only 12% of women use fertility services to receive help conceiving a child. In Alaska, we have not had access to specialized assisted reproductive procedures that are now available. What are the causes of infertility? When should you see an infertility specialist? What help is available to achieve pregnancy? Let's ask the expert these questions and more. Joining us today is Dr. Katie Ostrom. She is a board-certified OBGYN specializing in advanced infertility treatments at her practice in Homer, Katie Ostrom, MD, LLC. She attended medical school at Baylor College of Medicine in Houston, Texas, residency in OBGYN at the University of New Mexico before moving here to Alaska. Dr. Ostrom, welcome. Dr. Ostrom, thank you for joining us. I am very excited to tackle this subject. It's a very large subject, so I hope that we could get through a lot of information. Now, you've worked as a general OBGYN, so I'd love to hear about what led you to specialize in fertility and infertility and how that led to you starting your practice in Homer.
Right. Well, like many of my patients, I struggled with fertility as well. So when I had come to a point of my career where I had decided to start a family, I was struggling. And I was here in Alaska and working with other generalist OBGYNs, and we all had the capability of doing some basic fertility work. But the two big names in fertility work in Alaska at the time was a certified nurse midwife named Joy Zimmerman Golden. She is now retired, but she still is very active on the West Coast in fertility work. She helped me to conceive my first child. And from there, I think the energy for this and the desire to help other people really blossomed at that point. When I moved to Homer to start my own practice, I knew that there was another big name in fertility, a best-kept secret that we had in Alaska. That was Dr. Nels Anderson of Soldotna, and he was a well-loved family practitioner who also had the desire to help women to conceive pregnancies and start their families. And he was a self-trained, self-taught specialist in vitro fertilization, and he offered that to women in Alaska who were willing to come down and see him in Soldotna, and he had quite a good success rate with that. When he passed in 2019, I reached out to his family because I was hoping to continue his legacy, and they were so kind to bring me on board. They donated their lab and their equipment to us, and that is how I was able to connect with a team that I could put together using an embryology lab called MedTech for Solutions and a reproductive endocrinologist, so an OBGYN with additional training in vitro fertilization. And that was Dr. Gary Levy from Honolulu, Hawaii. He was available to come and get our program started.
Excellent. Yes, and I think that there are many of us who know Joy Zimmerman Golden. She has helped to start many families. And we were supposed to have Dr. Levy with us today. He has quite an interesting career. So as you said, he is an OBGYN, but also a reproductive endocrinology and infertility specialist. Tell us about how that works with him. He's living in Hawaii, but he comes here to work. And does he go other places as well to work? He's created quite a niche.
Exactly. He has quite an interesting career. He's based out of the Tripler Army Base in Honolulu, and he's a residency program director there. When he decided that he wanted to expand his interest in helping women throughout the United States, he actually developed a company called Fertility Cloud, which allows women to do their fertility work online through a telehealth platform. Once he was able to secure his licensure in all of the states so that he could help women throughout the United States with this program. That allowed him to also use his license in Alaska to come up and help us start our program. So he is able to come up at least 4 times a year. We are able to take our patients who are interested in having the IVF procedure done, and we bring them all together for a certain week during our fertility week. That allows them to have their eggs retrieved, and we're allowed to put back frozen embryos from our prior cycle, and that's how it's been working now for the past 2 years.
Excellent. So does he work with other general OBGYNs or even other providers in other states?
Yes. In fact, that is one thing that we love to stress is that there are so many nurse practitioners, OBGYNs that really enjoy working with their patients on basic fertility and then carrying them through that pregnancy into the delivery. So we don't want to interrupt that connection that a patient has with their OBGYN. What we'd like to do is consult with patients and OBGYNs who are needing that little extra step or having difficulty helping patients conceive after 1 to 2 years of work. We want to be able to facilitate them continuing their journey together, but allowing us to help if they need that extra step, and then returning patients back to their OBGYN, their nurse practitioner, their midwife, so that they continue their pregnancy care.
I like that. Well, let's get into it. Let's talk about infertility. Can you share with us the definition of infertility?
Right. Well, the basic definition of infertility is a disease that a couple experiences where they are not able to create a pregnancy or carry a pregnancy. And so this is something that has become very common, and we are seeing that not only are there male factors that we really need to address, there are female factors, there are different types of couples that are looking to create families, and that is what we're trying to support. Now, what the definition truly is a year of trying to create a pregnancy with using unprotected intercourse. But we do say that once you hit a certain age, and we do say for a woman after age 35, we would say shorten that to 6 months so that we can get your fertility journey started a little bit faster, knowing that we do have a little bit of a time clock with our eggs and egg quality after age 35.
Well, you talked about trying to conceive or trying to get pregnant. So I think we have to understand a little bit of the menstrual cycle and what that means to try to get pregnant, pregnancy, ovulation timing.
Correct. So we focus on the woman for this part in terms of having a period and having a regular period. Part of our work is to actually help women to have periods, have regular periods, and once those periods are regular, then we can assist her with determining when is the best time for her fertility window. When is the timing of ovulation happening? If you take the first day of your period and count that as cycle day 1, we're anticipating that you would have ovulation between cycle day 12 to 19. During that time, the follicles are developing until an LH surge happens, and many people are familiar with testing for ovulation in a number of different ways, one of those being a way to test for LH through the urine early in the morning. When there's a surge, we know that the egg is going to be ovulated within the next 24 hours. So we help a couple to focus on using that timing to create a window of time that they're more likely to have a pregnancy and a conception.
Okay, and you did say the first day of the menstrual cycle, and I like to tell people the first day of full flow as cycle day number 1. And there are a lot of, great apps out there that help you to determine your fertile days because you need an average of, I think, a few cycles to kind of know when the first day of one period is to the first day of the next period to the first day of the next period. So it's that first day that's quite important, right? So using an app kind of helps you to track that. So tell
There are
us.
so many apps. Yes, I'm sorry,
Yes.
Jen. There's so many apps out there, and they are such a good idea. But for patients not to get too frustrated, because there are some times where they might have a medical condition that doesn't allow their period to be regular, and the apps will be a little misleading. So talking with their OBGYN, their midwife, and their nurse practitioner, wonderful way to determine if those apps are actually accurate.
Right, and they can kind of help you to determine when your fertile time is. Now, you talked about ovulation and releasing that egg. How long does that egg survive after it's ovulated?
Right. The egg survives for about 12 to 24 hours in the woman's body. And that is why we actually ask that patients try to conceive for a few days prior to the egg coming out and covering that entire time period. So we would actually say for a couple to try to have unprotected intercourse at home about 5 to 6 days prior to when they know they will ovulate. And then through the ovulation time for about another 1 to 2 days. And that should really help most couples use that fertile window.
So we kind of want that sperm to be there waiting for the egg?
Exactly.
Okay. And how long does the sperm survive?
They'll survive for about 5 days on average.
So it can be there waiting for that egg. Okay.
Exactly.
Well, as a general gynecologist myself, I often find that young women are just curious to know their fertility status. So even prior to trying to conceive or achieve pregnancy, is a fertility consultation a recommended general practice, or are there only specific women for whom this would be recommended?
That's a great question. Knowing that we have shorter and shorter time to see patients these days, we do recommend that any women in their reproductive years or a woman that is expressing a desire to have a family be assessed for that. The first thing is to just assess for having a regular cycle. After that, it's looking at some habits that patients might have that might be preventing them from having a conception. And other things to think about are, we're researching a lot more about vitamins, supplements. We want to keep things as natural as possible. And just recommending that someone be on a prenatal vitamin with DHA, with folic acid, with additional vitamin D. All of those things are really important to make sure that egg quality is good.
And can this be combined then with the preconception counseling, the preconception testing to see if they have immunity to certain viruses and things like that?
Exactly. So we really want to try to think ahead in testing, maybe to make sure that patients are still immunized against the chickenpox or varicella, the measles. Other things to be aware of are just dietary changes as well. And then there's a little bit of testing that can also be done on just a routine panel. And that can also help to just make sure that the couple does not need additional or higher level fertility work.
That's very helpful. You mentioned the ovulation testing. So I think you were talking about the home ovulation testing kits where you pee on the stick and it measures that LH surge. Are there some other ways that women can assess their ovulation at home or signs to know that their fertility is, quote, normal?
Right. So there are some very inexpensive ways of doing that. And many of these things can be found online to guide women on how to do them. But the traditional way has been to do some basal body temperature testing. And again, very helpful for a woman who has a regular cycle about every 28 to 30 days. If there are any discrepancies in that, or after 2 or 3 months you're not seeing with your body temperature that you are ovulating, again, checking in with your provider to see if these are still adequate for you to use. Some women will notice a change in their cervical fluid, and that will be an indication for them that they are actually having an ovulation.
That tight, sticky egg white mucus?
Exactly,
yes. Okay.
Exactly.
Yes.
But not all of us make that, so definitely not to be frustrated. There are other ways of testing, like you mentioned, the urine testing kits that are now become very accessible and inexpensive.
And then I guess even just having a regular monthly period that comes approximately every the same amount of days between each period each month is kind of a nice clue that things may be happening.
Absolutely. That's a great start.
So, moving into infertility, who should have an infertility consultation? You did give the definition. So, the 1 year, less than 35, and then at 6 months. What about at 40? Is there a different timeline for that?
Right. Well, at 40, we would probably tell our patients to come in after approximately 3 cycles of trying. If there's any discrepancy in the cycle, maybe the cycles are starting to lengthen. We're having more of a 35-day cycle. Then we definitely want to see patients because there's many ways of still helping people to regulate their cycle, very simple medications to use in order to just get that back on track. So we would say that, if a couple has been at that year mark, or if a woman over 35 is between 3 to 6 months of trying something at home, to come in and have a pretty basic assessment, including some labs, maybe an ultrasound, and potentially a semen analysis. We can't forget our guys who are a third of the time, that is where we're finding an issue with fertility.
Is there a reason that someone should have an infertility consultation before they've met those timelines?
There are a number of medical conditions that we definitely want to help women with. And some of these terms I think women are very familiar with, things like polycystic ovary syndrome, having endometriosis. Maybe a couple has some thyroid disorder going on. All of those things can absolutely affect the cycle and can be evaluated quite simply and treated very effectively.
All right. And who should they see for this infertility consultation?
I believe that everyone should start with their current provider. Family practitioners, their routine OBGYN office, a nurse practitioner who has an interest in women's health can be very helpful to get all of this rolling. And once all of these things have been done, if there's any concerns, then we would say a reproductive endocrinologist can definitely be helpful.
Is the workup different that they would get from their primary OBGYN or primary provider versus the reproductive endocrinologist?
Yes. So the basic workup, if an OBGYN, a nurse practitioner, a family practitioner, if they are comfortable interpreting some of the results that come back from a basic workup, meaning the lab work, the ultrasound, then they would be able to take care of that themselves. However, there are some couples who do have some very unusual endocrine problems that might need to be taken care of at a higher level. There's also some patients who have had recurrent pregnancy loss. This is also kind of a big topic that we would ask a reproductive endocrinologist to help us at that time. Because there are some autoimmune diseases, there are some what we call thrombophilias, or ways that women clot their blood too much. There could be very subtle changes in our own karyotype, which is our own genetic makeup, that need to be addressed by a fertility specialist in order to make pregnancy successful.
Yes, I've actually, identified some of these karyotype discrepancies where, genetically they're not 46XX when you're talking about their chromosomes. I have seen a couple of women with Turner syndrome. They were the 46XO, right? And many of them, not diagnosed, but had all of the classic signs and symptoms of this disorder and, had been trying for quite some time to get pregnant, unbeknownst to them that it was not going to happen, right? So, yeah, pretty important. Well, is age just a number? Women are waiting, to much older ages due to career or even here, the availability of infertility services and not knowing how to take that next step. So can you tell us about the risks of pregnancy over 35 and then over 40?
That's a great question. In terms of getting pregnant, we know that our egg quantity or the number of eggs that we're born with will diminish over time. And we see that continue to fall off pretty dramatically after age 35. And so between 35 and 40, then 40 to 44, which is where we actually recommend that people consider using a donor egg at that time. We want people to be encouraged to continue to work on their own egg quality, knowing that the egg quantity is also diminishing, hoping to be pregnant, before needing a donor egg. But we do worry about pregnancies after age 35. This is where, the egg quality, where we talk about the genetics of the egg, may turn out to cause recurrent pregnancy loss or some other genetic conditions in a child. So we want to be very cognizant of that. We also know that women over 35 are slightly higher risk for developing gestational diabetes. They might develop blood pressure issues along the spectrum of toxemia or preeclampsia of pregnancy. We also do see a little more miscarriage and a little more stillbirth as we get into our 40s. So we definitely want to be cautious of that as we counsel our patients becoming pregnant over age 35.
Okay. Well, thank you. That's a lot of information already. It's time for us to take our first break. But when we come back, let's talk about infertility treatments that you offer in Homer and hopefully soon in Anchorage. So I do want to acknowledge that in today's program, I'm using a lot of heteronormative terms, and that's for simplicity's sake. So when I'm saying woman, I'm referring to someone that's born genetically female. And when I'm referring to a man, I'm referring to someone who's born genetically male. So, Dr. Ostrom, now that we kind of understand how to get pregnant and we understand some of the causes of infertility, can you tell us about the infertility treatment options, maybe starting from the simple to the more complex?
Right. And this is an area that many OBGYNs can help their patients with in order to try becoming pregnant. And some of the most common things that I think most people are aware of are medications called Clomid and Femara. This is two non-hormonal medications, but Clomid is a selective estrogen receptor modulator, and Femara is an aromatase inhibitor. Now, these two medications can actually work with a woman's system in order to enhance her own ovaries to create a follicle that creates an egg ready for ovulation. And this is one of the most simple ways that can be used during the cycle. It's taken for 5 days of the cycle, right after the period, somewhere between day 3 and day 5. It's given for a 5-day course. From there, ovulation can be detected and timed intercourse can be had. Some women will need a little more oomph to their egg production and ovulation. And there is when we try to use injectable medications. So now we're taking follicle-stimulating hormone in a more concentrated form and using that as a little subcutaneous injection during certain days of the cycle. Then that does bump that up to a little bit higher level of care. And we would just recommend that a clinic that is wanting to do more controlled ovarian hyperstimulation have the staffing, the time to put into those patients who will need a little more monitoring. When you increase your amount of medication you're giving to a woman, you want to be so careful not to overstimulate her ovaries. And so using ultrasound, using lab work, being available to your patients is very important when we get to that level. Now, some women and men who are trying to conceive have a male factor, and we might need to do an insemination. So that's another level of care, and we do recommend that when we are stimulating the ovaries. We see a higher success rate when we're able to concentrate the best sperm and put it close to the eggs that are ovulating. So insemination is something that can also be done through many clinics in Alaska. And that insemination process does get timed to the woman's ovulation. And again, being very careful to follow standard guidelines so that we don't have too many pregnancies with multiples. We want to be very conscious of that. Many people know that Clomid can increase your risk of twins about 7%, maybe a little higher than that. And so we want to just support our clinics that are trying to help patients get pregnant, but not taking it too far.
Right. You mentioned a couple of terms. I want to just go back over. One of them was ovulation or ovarian hyperstimulation. So you're wanting the ovaries to release more than one egg with those medications. Is that right?
Yes. So for some couples, producing just one egg per month that is mature and ready to meet the sperm is the goal. There are times when we recommend that a woman produce 2 to 5 eggs and have those ready. And during those times, we want to be able to control that stimulation so that she doesn't overstimulate. When you overstimulate the ovaries, that can lead to some other medical conditions that we want to prevent.
Okay. And then you also mentioned FSH. So we just want to talk about this is something that's released from the brain, from your pituitary to stimulate your ovaries to produce those follicles. So follicular stimulating hormone. So some of these, medications and things we do may be manipulating the FSH to stimulate the ovaries more.
Correct. And we want to do that just in a controlled way. First, making sure that the egg is receiving all of its nutrients that it needs, plus its stimulation. And we do that with concentrated follicle-stimulating hormone.
Okay, great. All right, so we've talked about ovulation induction with medications by mouth and injectables, and then intrauterine insemination to kind of get the sperm further down the field. I guess we're not putting them together with any eggs, but we're getting them closer to the goal, so increasing your chances, right? What's
Correct.
Next?
So then once a couple has tried this for about 3 to 6 cycles, then it's time to investigate a few more things or move on to IVF. Now, with IVF, we are going to make sure that there are no other inflammatory conditions that are preventing implantation. We're going to make sure that the cavity has been assessed to make sure that it can accept an embryo. And we're going to talk with couples really specifically about this, next step, which is quite intense for couples. We have to do a consultation with a reproductive endocrinologist, so we, of course, use Dr. Levy to do that for Alaskans. Once we have determined that a patient would like to proceed with IVF, we do put them on a suppression of birth control pills. Then we turn on the system for about 10 days of stimulation. And again, these are with the concentrated medications like follicle-stimulating hormone. And as they progress through those 10 days, they are developing and maturing as many eggs as possible. And then we have them come to Homer, and we retrieve those eggs, called a vaginal oocyte retrieval. This is done with an ultrasound and a needle that is able to aspirate the eggs from the ovaries. And we do use some sedation for that because we know that that can be quite an uncomfortable process. Once those eggs are retrieved, we have our lab ready and set to go to help fertilize those eggs. We incubate them for 5 days and then freeze them after that. In about another month, they'll come back and they'll have their frozen eggs replaced into the uterine cavity. And within about 7 days, we will know if they are pregnant.
Excellent. Do you always incubate those for 5 days? Do you ever freeze them after 3 days, or is it common now to wait the full 5 days?
We do like to wait the full 5 days, and in only certain cases will we only do a 3-day. Every few days we are assessing them. So we give patients a fertilization report the next day we give them a 3-day embryo report, see how many embryos survived to day 3. Day 5 is very telling because that is where we know that those embryos have survived full 5 days. They're in their blastocyst stage, and they can be frozen easily at that point. They can also be tested at that point for the individual genetics of that embryo. So that day 5 is a key day.
That's exciting. I'm excited that this is a service that's available here. Dr. Ostrom, we have a question or comment from Gabriel in Homer. Gabriel, welcome to line 1.
Hi, can you hear me?
Yes.
Yes.
I was just, it was more of a comment. I had my first child at 34 and then around age 40 wanted to have a second and used a natural tracking method of basal body temperature and cervical fluid to track my cycle, and it was very helpful. I think I knew I was pregnant probably within 5 days of my temperature reading. So I don't know if that's something that is ever taught. Obviously, you have to be pretty consistent with it and keep your notes and all that, but it was very helpful for me.
Oh, right. Thank you for sharing. Yes. So, Dr. Ostrom, you touched on the basal body temperature a bit. Do you see that women are being educated on how to use this process throughout their cycle, really, to see where they are in their cycle and that, ovulation is occurring?
Yeah, that's a great comment, Gabriel, because a lot of times we tend to think of fertility. We want to use all the greatest, latest technology. And we have to remember that our bodies can actually tell us what we need to know. And so for a woman that is having routine cycles, learning how to do basal body temperature charting, it takes a little bit of skill and a little bit of time. And thankfully now we have a lot of information online that helps patients. But you're right, going back to the basics and using, reading a woman's body and helping her to do that herself, extremely helpful.
Absolutely. Especially now people are trying to become more natural and use more natural methods. And, even when it comes to food and having less processed food and less medication. So yeah, back to basics. I like that.
Correct.
We have another caller. We have Lucy from Fairbanks with a comment. Hi, Lucy. Welcome to line 1.
Hi, you can hear me?
I can. Hi.
Hi. So I was a patient of Dr. Anderson's almost a decade ago now, and I wanted to, ask if you're continuing in that sort of, in other words, when he was a physician, it was a bit of a kept secret, right? That you could go down to Dr. Anderson and not have to pay $20,000, $30,000 because, many companies don't cover insurance for fertility treatments. And I was also amazed by his kindness, especially, it was a man and it worked. And so I have a child. But my question was, do you continue with those sort of low prices? For us, we had to, buy our meds and everything and have them shipped, and you had to think about, is it going to arrive in 30 below and sit on the porch? And so there were all these extra pieces related to Alaska that I was curious if you all have thought about.
Oh, that's wonderful. Yeah, very important things. So the cost, and definitely when you're trying to get medications here, that is very stressful. So that's an added element of stress to IVF. Dr. Ostrom.
Yeah, so this is one of my favorite things to talk about because absolutely there is a sticker shock to having infertility treatment done. And so I wanted to carry on his tradition of lower prices. That was really important to me because I didn't want women who were then wanting to stay in state and have these services have to pay exorbitant prices. Now, one thing I had to do differently from Dr. Anderson was bring in a embryologist and a reproductive endocrinologist to help me. And so the costs that we do ask patients to cover we are not making money on this IVF. We are actually covering our expenses, and that's what's really important to me, is to have this service available. We've had to replace some of the equipment and do some things a little bit differently than Dr. Anderson did, but we do ask patients to check other places and check those prices, because we have tried to keep them as low as we can for the day and age that we're in and the equipment that we have to have. But that was important to me. We also help patients to find grants to cover. We'll work with insurance companies, which are now more and more accepting of the fact that this is a disease for some women. They need that to be covered. And we are happy to work with patients, especially on medications, and finding the cheapest resources for those. So you bring up a great topic there, Lucy.
Dr. Ostrom, this brings up a question, and thank you, Lucy, for that. This brings up a question about cost sharing. So I think I shared with you that I went through IVF myself, and I know at that time they had a program where you could share the cost with another woman that you don't know, perhaps sharing, if they're unable to use their own eggs, sharing the cost of donated eggs. Have you seen anything? Is that still happening, or is that something that hopefully, maybe in the future that would be something that would be offered?
Right. We looked into a lot of that when we first got started. And because we've now been in practice for 2 years, we are applying for our FDA certification, and that will put some restrictions on us. Things have gotten a little bit tighter in that world, not only with HIPAA and being careful not to share information. We also have to be careful about prescribing medications that might be shared. So, yes, we do talk with patients about that. We try to get in as many donated or sample medications from companies that have that to share. But we are very much into connecting people, but in a very safe way to allow them to have that discussion.
It is also nice to have a connection, even though HIPAA is very important and the privacy of patients is important. But there is so much strength in community. And you find that in many different disease management situations, that hearing from other people is so powerful, and also, can help reduce stress, which can be a killer for many things, right?
Absolutely.
Okay.
Absolutely.
So are there any hard stops when it comes to being a good candidate for IVF at your office? I know that at many offices, there's an age cutoff. So after 42 or 43 years old, they will not allow a woman to use her own eggs. She can get a donor egg from another woman, and then she can become a gestational carrier, basically. Do you have any of those hard stops, and where do those hard stops come from?
We definitely have some recommendations, but it is dear to our hearts to continue this process for women as long as they know their own risks of using their own eggs. We will not turn a woman away for age. We certainly recommend, and that is more of a national standard, recommending that at 44, a woman consider using a donor egg. But we will very much support a woman who wants to be going through this journey, knowing that the cost, the stress on her own body, the egg quality, if she's aware of all those issues that we bring up, we would still help her, after age 44. We're very much wanting people to create the families that they desire.
And you discussed some of these risks, and I know one of them is the increased risk of genetic mutations. What are some of the other risks of in vitro fertilization?
Well, so there are a few risks with taking medications that increase your estrogen and progesterone levels. So we're very careful to monitor labs all throughout the process. During the actual procedure for the egg retrieval, there could be a little bleeding involved, or we definitely give antibiotics to prevent infection, but those are pretty minor. We do also take a lot of care with the ovarian hyperstimulation syndrome that can occur, once the eggs are aspirated out and all the fluid is removed from each follicle, they can actually rebuild the fluid into the ovary and actually expand the ovary even further. And this can cause some metabolic issues in the first week after retrieval. But there are now ways to pre-medicate for that, and we've been successful doing that. A medication called cabergoline can be given for a week prior to, and that will reduce a woman's chance of having this ovarian hyperstimulation we call OHSS, which can be quite serious if not controlled.
So you talked about the process in Homer, which actually doesn't seem like it would be that much of a strain to go to Homer for people that are outside of Homer. But there are some exciting plans that are in action to move to Anchorage or to have a satellite clinic. Can you tell us more about that?
Yes. So we have enjoyed our success here on the peninsula, but we realize that a more central location would benefit most patients in Alaska. We'll have people being able to fly in a little easier. We'll have less weather concerns, and we'll have an easier way to get our supplies. So as you can imagine, doing something like this in Alaska, bringing liquid nitrogen down to Homer on a routine basis has been easy so far to do, but we want to anticipate that that could always be an issue. We have to be sure that our embryos are frozen at all times, and we've been easily able to do that. But we feel like that would serve patients better to be in a more central location, and so our plans by the end of 2023 would be to move our lab to the Anchorage area.
That is so exciting, and you'll hopefully be able to reach more people. How are you reaching people now so that they know that you're there and you're offering these services?
Right. So we started out with just word of mouth. We wanted to make sure that we didn't get too big too fast, that we took on too many patients that we could accommodate. And we've been slowly growing over time, mostly by word of mouth. We do a little advertising, sending out some information to family practice offices and OBGYN offices throughout Alaska, and using our website. And we've been able to steadily build our program from there, and really just keeping it a little bit on the down low till we're sure that we could get our FDA certification and our SART certification. And those are coming along very nicely. And then we'll be able to easily expand once we're up in Anchorage.
Great. Well, another opportunity that you've afforded us afforded Alaskans is availability of fertility preservation. So egg freezing and embryo freezing, right? Can you tell us about that? I think that is very exciting to reach patients who may not be ready for pregnancy right now, but want to have a sort of insurance policy for the future.
Yeah, so that is something we've been very excited to offer. So first of all, we do offer sperm freezing. There are a lot of our couples where the spouse is deployed. People work on the slope. They're not able to get back for a cycle for an insemination. So we are freezing sperm and holding those for patients for when they're ready to use them for either insemination in the office or with in vitro fertilization. We also hold dear to our hearts our young people who are undergoing or will need to undergo cancer treatment. So we have some men that come and they bank their sperm with us so that we have that for them before they undergo their chemotherapy or their radiation. And we're also available to do egg retrieval for women that would like to have their eggs removed and stored frozen before they undergo maybe a gynecological cancer surgery or treatment. We also will help families who really do want to postpone, but they want to kind of freeze that egg in time. And they will come and freeze eggs with us, which we're happy to say now is a better technology. When we first started freezing eggs, we didn't quite have it right. And so the percentage of eggs that could survive in the U.S. with freezing was just pretty dismal. It just was not good and very expensive. But the technology is so much better now, and so we're having so much better success with freezing eggs, and we are happy to now offer that in Alaska.
Yeah, I would think that an egg is, typically one cell, right? And then an embryo is multi-celled, so that egg seems more fragile than it would be to freeze your embryo, which is the fertilized egg.
Exactly. And so we do encourage couples to create embryos if they are able to. And if a woman is freezing her eggs, if she has chosen donor sperm or she has a partner's sperm to make embryos, they are still, it is better to freeze an embryo than an egg still. We are finding that. It's just that egg freezing has just come leaps and bounds ahead of where it was.
That's good. Well, and the process for egg freezing is the same as it would be for IVF. Is that correct? You'd have to stimulate the eggs because you'd want more than one, especially if you're freezing this. You'd have to take some medication to stimulate it and then do the same withdrawal of the eggs procedure.
Yes, so you would go through all of the stimulation process, the vaginal oocyte retrieval, and then we would just freeze the eggs immediately that day.
Okay. And then you keep those eggs here in Alaska?
Yeah, so we've been able to do that. There are liquid nitrogen tanks that are used to store all of the frozen specimens. And that is really the most basic and simple way to store things adequately. And then that liquid nitrogen is just, replaced and kept at certain levels. So it's a very simple but effective way of freezing that most IVF clinics use.
And I know for couples that may move out of state, they have a job for everything, but there are specific transportation carriers that you could use to get your frozen specimens where you need them. So I know that's probably a question that people have. What if I go somewhere else? Or what if they're moving here from somewhere else where they already have frozen embryos or eggs? They can be transferred using one of these methods. It may be more difficult here, though, I would think.
Yes, that brings up a really great question about that. There are tanks that we prepare and we put the tissue in a very standardized way, and we're able to FedEx those out of the state. Couples are also able to send things to us. It's a little bit of paperwork and a little bit of a process. If we have something like frozen eggs or frozen embryos, those require a little more handling that we bring our specialists here to do. But we are always able to send people's eggs, embryos, and sperm wherever they would like to have their treatment done.
Okay. These are questions that you probably don't think about until you need them, and then you don't know if this is something that can be done. Another one you touched on is the cancer diagnosis. And I feel like not every woman of reproductive age is referred to an infertility provider to discuss this. And I hope the numbers have been going up, because definitely I would want that woman. So many choices are taken away from you when you have cancer. So giving you the choice to freeze your eggs or embryos to be dealt with after your cancer treatment is so important. So I think that's an extra step that probably has to be done quite quickly after you've received a diagnosis. But to have that ability to preserve your fertility is so important if you want it.
That's so true. We want to work really closely with a woman's gynecologic oncologist or any oncologist that's working with a woman to be sure that our treatments that we would recommend for IVF would not worsen a cancer diagnosis. And we're hoping that when we're in Anchorage, we can offer our sessions, more sessions per year. Right now we're at 4, but we recognize that when you had a cancer diagnosis, you don't want to wait months and months, to have your eggs removed, store your eggs, your sperm, your embryos. So we're hoping that once we're in Anchorage, we can facilitate that even better.
Excellent. Well, we talked about the sperm freezing, and this is one thing where I think men have all the luck because they, regenerate their sperm every 60 to 70 days, and they can just go and deposit it in a cup, and they don't need all of these medications. So they've got that, but there are some men that don't ejaculate. So they may be making the sperm, but they're not able to get that sperm out. And so there are some special procedures. And I'm thinking about maybe a man with a spinal cord injury. And I know there are some special procedures where you can go in and get the sperm out for them. So what is that testicular sperm extraction? Is that something that is being done here?
So that is something that we are developing the ability to do. We've had a couple of patients ask us for that, and we have spoken with a urologist that is ready to offer that in our offices. We have the anesthesia services ready, and we are definitely going to be offering that.
That's wonderful. So really reaching out and helping so many populations of people. Well, we have an email from Cassie from Homer that wanted to ask you if you collaborate with any Chinese medicinal practices.
That is a great question. So we are open to people doing any kind of relaxation. Specifically, a lot of people ask us about acupuncture and whether that helps with their fertility success. And we know that the literature nowadays is telling us that it's not the end-all, be-all. It's not what we thought it was for helping with fertility, but we do agree that anything that's relaxing to a patient is not harmful, and we would encourage people to do all of those things. In relation to any other herbs, we have not necessarily seen that, but there are some interesting things coming out in the literature about Chinese herbal medicine that we're very excited to watch and see, because we would love to keep this as natural as possible and as inexpensive as possible. So yes, there are some things out there that are coming out in studies, and we're kind of excited to watch.
I love to hear more about how Eastern medicine meets Western medicine in that combination.
Absolutely.
Well, speaking of supplements, you talked a little bit about vitamin D and some other supplements. Can you just, in these last few seconds, maybe just give us what we can do to boost our fertility? Yes.
So I'll quickly talk about women over 35. For egg quality, we are noticing that CoQ10 in a dose of 300 to 600 is very good for egg quality. So we would recommend that as a daily dose for women over 35. We also think that vitamin D, somewhere between 2,000 and 5,000 units a day, is helpful. DHEA, folic acid, vitamin C, melatonin, all of these things can be helpful as well. So we would encourage that. And then we would just tell patients, watch your habits. Smoking, alcohol use can really decrease for men and women their fertility. So watch those habits, and you'll be well on your way.
Thank you so much, Dr. Katie Ostrom, for being with us today. Thanks to our audio engineer, Chris Hyde, and our producer, Madeline Rose. You can find more information on this and previous programs on our website at alaskapublic.org. Let us know your thoughts or suggestions by emailing us at line1@alaskapublic.org. This has been Line 1, Your Health Connection. I'm your host, Dr. Jillian Woodruff. Thank you.